take the pleasure to welcome all of us on this call and bringing the discussion today into context. You see the viral load cascade right from patient identification to result utilization. There are quite a lot that happens in between there. And what we are going to be discussing here is part of what really happens to make sure that the patient identified will eventually ultimately receive a service that impacts their care. So this is one part of the many things that we've been discussing, but putting it all together brings the services to the patient, and our aim is to see that the services eventually impact the way the care is delivered and the outcome that the patient, that the outcome of this care in impacting the patient welfare. There are so many system issues, and basically our discussion today is around the systems. And we are delighted today to have a subject matter expert by Jason Williams. Very vast, very well versed in the areas of systems, laboratory system building, around mapping, capacity assessment, sample transport, aiming at efficiency and cost effectiveness of our laboratory networks. So I don't think we will get somebody better at this. I think we are having one of the best to address this kind of subject, and I know we will learn a lot in this session. So I will not take a lot of time. We will have announcements at the end of the session. Just a few housekeeping rules. If you are not speaking, if you are not being asked to speak, please keep yourself on mute so that we don't get echoes that interfere with the communication. Then, have a question. Please put your question in the chat. As somebody will, in the course of the discussion, if something crosses your mind and you want to ask, put a question in the chat box. Somebody is going to read it at the appropriate time. Then please help us know who is on this call by registering your presence. Still go to the chat and indicate whether you are alone on your connection. Just write your name and where you are. If you are more than one, just write your name. I mean, just write where you are located, and how many of you are there, so that we can keep track. This is very important for us to keep track on how things are happening, and also be able to provide the necessary feedback whenever that is required. So with those few housekeeping rules, I will take the pleasure to welcome Jason to take us on. Jason is going to present in the next 25 or so minutes, and then we will react by asking questions and making supplementation on what he has presented. So Jason, take the floor, please.
Thank you so much, Charles, for the introduction. Hopefully, I've just pulled up the slides. Hopefully, folks can see that. Can everyone see that? Charles, can you see the slides?
Yeah.
Perfect. So good morning, good afternoon, good evening, wherever you're located in the world. I know that we have a mix of, it looks like some US colleagues as well as African colleagues. So thank you all for taking the time to join us to talk through some network optimization things that we've been working on actually over the past few years. And currently, network optimization is a relatively hot topic, particularly in PEPFAR. The COP guidance is pretty directive in basically pushing for labs to look a little closer at what's going on efficiencies. I'm going to talk shortly, probably about 25 minutes, as Charles alluded to, on some things about lab networks. And I'm going to limit the conversation a little bit, and I'll talk more about where I'm going to limit it in the future. But talk a little bit about some of the things that we're currently seeing in relation to some of the lab network that are currently in many of the countries that we work in. The broader network approach, which is a strategy where we're somewhat looking at the entire lab network and looking at instruments and diseases more agnostically and looking for overall efficiencies, or contract management. What is lab network optimization, how we define it, and the things that we do on the USAID and CDC side. CDC has participated in many of these lab network optimizations on the PEPFAR scope, as well as Global Fund. So I think we're pretty much in alignment with the overall approach and methodology. Talk a little bit of how we do it, and I'll give you a couple country examples just to give folks a flavor for the differences in what we could actually do on lab network optimization. And I'll talk about some of the challenges to doing this, and then some way forward thinking as part of some general sort of recommendations as folks think more broadly about their lab networks. So when we think about current networks in countries, there are many issues that we see. Obviously, right now, within the donor community, there are resource limitations, and there's an attempt to create some efficiencies to expand testing in the most efficient and cost-effective manner. We do see some fragmentation on sample transport networks, as well as parallel transport lanes. And that's partly just because of the fact that many programs have grown somewhat organically to address some of the access-related issues, and it becomes very, very difficult, particularly when you have a high volume of instruments, to stay on top of what's going on in relation to your sample transport network. We do see many instruments in many countries that are actually not well positioned in countries to maximize utilization, which is ultimately a cost-driving factor on cost savings associated with reagents. And we also see gaps. So the exercises that we look at are looking at replacing instruments, so it's forward-looking as well as retroactive looking to give folks an idea of where potential things could improve. I do think when we go into many countries, folks are very focused on their HIV networks when we're dealing with HIV colleagues, but they don't have a full appreciation of what's going on with the TB. And they don't have visibility into what's going on with some of their partners in relation to POC, for example, for many of the Unitaid projects for EID, and now viral load as we move to using viral load for breastfeeding women and infants and kids. We see very different strategies and considerations that various stakeholders have, and many times they're not quite aligned. And this is an opportunity to kind of lay everything out there in one kind of exercise so people can appreciate everyone's kind of investment and to get folks to kind of voice their interests in developing the lab network. And when I talk about what we do in the lab network space, particularly as around optimization, the primary focus historically has been instrument placement, looking for formalizing sample transport lanes, looking for opportunities to increase access, and then overall integration, particularly for HIV, TB services. Now, there are other opportunities to optimize lab networks, and that could be, HRH, that could be inter-lab optimization, looking at sample flow within the facility and creating workflow streams that improve overall efficiency. But the work that we're doing basically sticks to these 4 or 5 things that I've kind of alluded to. So what are some of the things that we've seen in relation to some of the exercises that we've done in relation to efficiency gains? As I mentioned earlier, we do have a lot of duplicative referral lanes that are actually separately funded. And the idea here is to actually integrate them, reduce costs, and create some overall efficiency there. So what we're seeing in some of the recent exercises that we've conducted is obviously we've got many gen experts that are out there. There's an opportunity to tap into those. We've got LPA, CD4, we've got obviously the viral load and IVT networks, and we do see actually in some countries where the EID sample transport network is actually separate from the viral load. This is an opportunity to understand both of those diagnostic needs and to integrate fully overall referral lanes. And what this does is it allows us to aggregate our pool funding and create overall efficiencies. I think, as I mentioned earlier, the evolution of sample transport networks in a handful of countries has been somewhat fragmented, and it's due to the fact that they've grown organically. And one of the things that we do try to get out of an optimization effort, particularly if the focus has been sample transport, is to look at standardized reporting and create some sort of centralized oversight, so we can actually strategize and target interventions where we actually do see gaps or actually poor performance in relation to sample transport lanes. Another thing that we do look at more recently, and that's looking at the breakdown or the split between plasma and DBS for viral load. We can use distances, we can use many different factors to actually target particular health centers for DBS and plasma only. So that's a nice thing to kind of model and to kind of understand where you're going in relation to those two sample collection methodologies. I think that the biggest gain here is actually giving you a forward-looking look at your program to understand expansion and potential opportunities to increase utilization in some areas where you may not be seeing good use of instruments. We do see commodity redistribution and distribution burden needs decrease, and that's because to do 100,000 tests on 10 machines costs more to do 100,000 tests on 5 machines, and that's because of the commodity distribution that's required. There is a minimum amount of stock that's required at each lab, and that the greater efficiency you can gain and the greater utilization, you do actually see commodity distribution reductions. Instrument maintenance, I think folks can agree that that has been a challenge, and some of that is due to just the sheer volume of instruments that you'll see in some of the other slides coming up. So there's an opportunity to kind of strategically assist the service providers in country to target areas where we actually do see high instrument failures regionally, as well as mapping them visually on maps, which is a very useful way to kind of represent what's going on. And I think more recently what we've seen is if we do have a very if we have an evidence-based optimization strategy with clear testing volumes delineated at each testing facility, it actually does give us a better negotiation leverage with manufacturers when it comes to pricing negotiations and developing strategies a little more comprehensively with some of the service providers that we're working with across the countries. So what is the network approach? As I mentioned earlier, it's looking at your complete national lab network, not just looking at the viral load, not just looking at the EID and TB separately, but collectively looking at what instruments are out there and where they're located. Agnostic of disease type. We know that molecular diagnostics is obviously the cutting edge, and it's the preference for many tests. And as we move into HCV, HPV, HBV, we start looking at some of these other OIs, particularly with TB too. The molecular testing need is increasing. So the idea here is to look agnostically at your existing instruments and understand how you can actually integrate different diseases and increase testing volumes at key labs. Now, the one thing that is necessary to do that is to actually understand. So you'll see some of these maps and some of the examples later on to give you a better appreciation of what we're looking at in some countries. And what we're pushing, you'll see this coming out in the next few months, is a more all-inclusive per test cost. And what that does is that actually allows you to develop a strategy that is additive with testing volumes. So you're aggregating viral load EID, potentially TB, and other tests to reduce the price per test cost. But when we're looking at all-inclusive pricing schemes, it's looking at the instruments under reagent rental, it's looking at inclusive service and maintenance, it's looking at data connectivity solutions, and any additional kind of technology that the manufacturers have available that could assist you with your instrument usage and getting visibility on performance. And ultimately what we're doing is trying to ensure commodity availability. One of the things that we are doing as part of the all-inclusive per test cost is actually pushing activity with instruments to actually look at consumption of manufacturers so that they can take a more responsive role in keeping labs adequately stocked. So we don't have these pass-through sort of procurement mechanisms where we buy from a manufacturer, bring them into country, send them through a central medical store, send them down to labs. It's more of a seamless commodity flow using the manufacturer's visibility off of the machine. So I hope that's clear, and if it's not so clear, then we can talk a little bit more during the Q&A section. So what is network optimization overall? Again, we're looking at 4 or 5 of the key things that I mentioned earlier. I think when we think about optimizations, it's basically maximizing the use of what you currently have. We're actually looking at creating an approach that would be more efficient as part of addressing your overall programmatic expansion. As I mentioned earlier, this could include placement, your current instruments, as well as planning future, and then looking at different sample transport options. I think the nice thing here is you can actually model a POC integration strategy prior to actually moving anything around. If you're looking to add an additional machine in a poor coverage area, you can actually see what that would actually do in relation to sample transport lanes and how that would actually impact testing volumes at other sites. So it's a really good opportunity to kind of help assist in making decisions by modeling and see what would potentially happen by placing an instrument or moving an instrument in virtual kind of world. And I also want to iterate, in some of the optimizations that we've done, I think folks look at it as a fixed solution, but it's not. It's a dynamic kind of process, and any new change or any new thing that you learn about your program could potentially influence what your network optimization strategy looks like. So I just want to make it clear that, when we do these things, it's not a definitive final model. It's a starting point that kind of evolves over time as your program develops or evolves and matures. So here are just a couple of these examples of what we've kind of done historically. I think the nice thing here, particularly as we look to Rwanda, this is something that they did somewhat independently after getting some lab network optimization training that was conducted in Uganda a few years back. If you look at the lower, if we're looking at the left map in the lower right, that is what they're, I know it's not very clear, but what we're looking at there is their existing CD4 network. And as we know, the demand for CD4 is somewhat decreased. So Rwanda was actually looking at, using their existing footprint and looking to reduce the overall instrument burden to create further efficiencies and create a more referral-driven CD4 approach over the POC kind of approach that historically was in Rwanda. I think the nice thing here too is that the referral hubs that you're looking at here are actually POC machines because the demand decreased. So it was a nice look at reducing the footprint by 50% actually in Rwanda. If we look off to the right, we're seeing a lot more complex sort of optimization here. Nigeria in the past, and actually currently has a network of 27 labs. The idea here was to reduce the overall footprint due to costs, because of the funding streams and the inability to sustain a network of that size. So we reduced the network to 16 labs and then looked for optimizing sample transport lanes, which then ultimately informed instrument demand at certain hubs. And then we overlaid the TV network on top of it. And the interesting thing to note here is that there was about 85% overlap between the TV network and the HIV network. And we used the tool to kind of create those linkages so we could maximize the integration between the TV program and the HIV program overall. And I think with Nigeria, the nice thing here is that they are looking to expand their EID coverage. And with the Gen Expert, they have many machines, and there's a really good opportunity, particularly as part of this exercise, to potentially capitalize on that large footprint that they have. So when we think about the process of network optimization, it's relatively complex and can take a very long time. Many of these exercises have taken over a year to sort of evolve. The last 6 months usually get very data heavy, but the big push is getting political will and overall buy-in that this is something that needs to be done. With the amount of effort that it takes, it's very important that you do have political will and you actually advance and move along with the output of the optimization to actually create efficiencies. It's not enough to do the exercise and to kind of look at it and put it on a shelf. You actually have to execute against it. We have seen some challenges with countries clearly defining their goal, and that becomes a little more crystallized as they go through the process on what their actually priorities are for their optimization. So that's kind of a nice iterative process that we kind of go through prior to actually doing one. There's a very significant data collection effort labs, the instruments, the testing volumes, all of the sample collect sites, programmatic patient demands by all of those sites. We can actually start looking at, how do we optimize referral linkages? And then we link that to GIS data points, and then we use tools that create various scenarios based on some key consumptions. And then we do this initially to kind of refine some of the models. And then we go into country in a very large workshop usually, and we do these things in real time. So we present some initial models, we get feedback, and then we iteratively adjust the models so that everyone in the country understands how we did it, why we're doing it, and everyone can buy into the actual execution of the optimization strategy moving forward. This is a very, very key thing. During some of the downtime during those workshops, what we actually do is we develop an implementation plan, which includes all of the training, all of the costing components, and looking at how we could actually move forward with doing an optimization and implementing it. So I'm going to talk very briefly about two country examples. I was involved in both of these. The Zimbabwe one was more recent, and Nigeria was one of the first ones to actually go through this sort of exercise more broadly. The Zimbabwe one is very different from the Nigeria one, as you'll actually see. Nigeria, we were looking to compress and reduce the number of machines, or the labs, and the Zimbabwe, they were actually trying to understand where their capacity was and how they could actually address their testing volume demand in the short term, and then understand where they would need to go in the longer term. So the Zimbabwe one is more additive, whereas the Nigeria one was actually compressing and reducing the footprint. So it's very different ways of looking at it. So I'll start with Zimbabwe. So here you can see at the time, this was done last year, and what we're looking at here is the current instrument footprints in Zimbabwe by type as well as by capacity. And what we're looking at here is a testing volume of about 1.7 billion. And the coverage or the need in Zimbabwe at the time was about 1.6. So when everyone sort of looked at the instrument capacity, they thought everything was great. But what you can see moving forward is that the instruments were in the wrong location, not necessarily in the wrong locations, but the demand in some of the provinces and regions exceeded the capacity in some of the facilities. And I'll show you the impact of that more broadly. But what I'm going to do here, just to simplify some of the process associated with doing one of these, is actually looking at an example of EID in Zimbabwe, which was very, very challenged just by the existing footprint that they were actually using as part of providing EID services. So in Zimbabwe, they had 3 conventional labs that were actually providing EID services. They were looking at this based on, historically it started the NRL, then there was a reference lab, and there was one that was cited in a high burden area. And they kind of stuck with that because of the fact that they were comfortable with it, but they were experiencing significant TAT times with EID samples. And there was batching of samples if it wasn't high volumes, and the samples were coming in somewhat inconsistently due to labs, or sites, batching prior to delivery. They were using the Roche-Caf CTM model, and they actually had a variety of machines that they could tap into as part of doing EID service to expand coverage. So what we did is we actually mapped all of the instruments that could provide EID in Zimbabwe. And what you can see here is you can see EID that could be provided on the Abbott M2000. You've got the BM Nucleosens, you've got the Gen Experts, you've got the Hologic Panther, you've got the Roches, and you've actually got Sambas in here too as part of viral load. But what you can see is that there's dense populations or density in some of the instrument coverages, and this was particularly interesting for the TV colleagues. But what you can see also is that there are some sites that are actually co-located, so we can see Gen Experts with Alir Qs. But what you can clearly see is if we compare this to this, there's a real opportunity here to actually expand EID coverage by tapping into some of these many machines you can see that are spread pretty well across the country of Zimbabwe to actually improve EID coverage overall. And this is what the software developed in response to the current instrument footprint. What we did is we looked at the pregnancy rates within each one of the sites and the EID demands, and we had the software develop sample transport linkages to labs that would actually potentially provide EID services. Now, the interesting thing here is that in Zimbabwe, they limited their reach to maintain provincial segregation of facilities in some cases, more specifically in viral load, but less so in EID. But what they saw is that obviously there was a significant opportunity to reduce turnaround times by capitalizing on many of these instruments that they had scattered across the country. So this is what the tool generated. And what came out of this also was an Excel sheet that actually defined the site to lab linkage within each one of these facilities. And the machine, the software that we actually use adds up all of the tests that are going to the machines to determine whether or not there's actually enough capacity to provide those testing services in that particular region. And if it doesn't, you know, you can change the machine out with a higher capacity machine, or you can actually redirect them, which is a really nice thing as part of the modeling solution. This kind of gives you an idea of the difference, you know, between what we were looking at as part of the original versus what the software tool can actually provide to you. So you can see this particular region in Zimbabwe, you know, the before and the after, and you can see it's a very clean linkage. And what it does is it actually creates 100% coverage in relation to sample linkages. So it's a very significant difference between the before and the after. And I just wanted to illustrate what this actually looks like more closely. This was the final overall integrated sample transport network that was developed in Zimbabwe. It looks very, very complicated, I know. But again, what you can do is you can segregate this through the Excel sheet to actually create a formalized list of linkages for EID, TB, as well as viral load. The labs, the triangles are scaled by testing volumes, as well as some of the other stars and X's that you see there. So we actually do know the projected testing volumes that will be established at each one of the labs, and we are ensuring that the existing machines are capable of providing those services at those facilities if the sample transport linkages that are developed here as part of the optimization are adhered to. So this kind of gives you a flavor of kind of what's going on in relation to a complete integrated lab sample transport network between HIV, TB, which also included the EID and the viral load collectively. And this is why we were doing it. If you look at the top graph, you can see, you know, as I mentioned earlier, they had enough testing capacity to do about 1.7 million tests with a demand of 1.6. But you can see, you know, that they had some deficiencies in capacity in many of the provinces. So what we tried to do, if you compare the top graph with the bottom graph, the top is the before and the second is the after. And what we were trying to do is create an optimization strategy that would cover Zimbabwe for the next year, 2 years. So what we did is we increased some of the operation times. We actually moved 1 or 2 instruments to a different location to allow them to have enough capacity within each one of their regions or provinces to allow them to adjust for project scale up. But as we moved into the year 3, you can see the gaps start to appear. So what this allows Zimbabwe to do is to understand, okay, look, we have enough capacity if we optimize based on the model, but we realize that as we move into year 2, we really need to start addressing some of the deficiencies that are going to be coming up as part of year 3, and think about what machines we're going to place where. So they would actually have to revisit the optimization to address those year 3 deficiencies. Nigeria, I'm going to come up in the interest of time. I'm going to go through this relatively quickly, but again, this was a really complicated scenario development. We started based on the existing referral network that was somewhat fragmented and it didn't provide 100% coverage. We mapped all of the existing 27 labs, and then what we did is we had the tool based on the current footprint, create an optimization scenario. What it actually illustrated was that even though we had 27 labs, many of the labs would not be able to cover the testing volumes if we actually optimize the sample transport network. So we understood, again, that the current lab capacity was deficient in certain areas. And you can see here that the green boxes are scaled based on ART demand. And what it illustrates is that there are some areas that have some high density, and the current instrument footprints and referral linkages were inefficient to address the demand if we were to reduce sample transport lanes to create efficiencies and reduce turnaround time. So this was really, really nice to kind of illustrate, and it gave folks a better appreciation of what needs to happen to create an optimized network with some efficiencies, particularly as it relates to their patient demand and their overall epidemics. So again, here, these were the 11 labs. So we've kind of scaled back here. And again, what we did is we optimized the sample transport lane. And what we identified is where the labs would be and what the testing volumes would have to actually be as part of going through these new 11 labs. And we identified that essentially we would need 6 mega labs that we would establish in Nigeria to accommodate testing volumes in some of these high demand areas. So this was an eye-opener for folks, and it also demonstrated that we could actually address coverage with a reduced footprint. So this was the final network optimization, and what we've done here is we've addressed the instrument deficiencies by placing instruments, potential instruments, that would have the testing capacity needs to address the referral network as part of, and what this identified is that they did need 6 super labs, and they have got actually some strategic high volume instruments, the Roche Cobus, or the Roche 8800, sorry, to address some of these high demand areas. Those labs now have been stood up, and they're actually moving forward now with implementing this optimization strategy. This was the full integrated PCR and TB sample referral network, where we actually laid on top the TB. And what this demonstrated, as I mentioned earlier, an 85% overlap between the HIV network as well as the TB network. So there was an opportunity here to leverage the viral load network for the TB program. And we do know now, as part of the optimization, the network sample transport that is actually executed now in Nigeria, we are seeing TB samples flow through this integrated sample transport network. As I mentioned earlier, Nigeria was the first to do this from beginning to end. And we started in March, and here's kind of a snapshot. This was a 3-month window, but there was a paper that was just published that looked at this more comprehensively over a 6-month period. And in the next few months, there'll be another paper that's written that actually gets at the cost savings. But I think, there's some really telling things here that kind of unfolded. I think the nice thing to see here is that health facility coverage did increase almost 75% because of the more formal structure of the sample transport network, clearly identifying linkages to labs. There was a significant increase in sample volumes, over 1,000%. In a very short amount of time, which did introduce some problems. It created some backlogs because we weren't adequately prepared. We didn't have the mega labs set up in a timely fashion to accommodate this. So we did see a significant increase in backlogs, but now those backlogs are worked through, and the testing volumes that are coming through the network now can be easily addressed due to the standing up of the 6 mega labs that are in place. So as I mentioned earlier, the integration, we've seen sputum samples, we've seen DBS, even CD4 going through these sample transport network. So it's a nice kind of demonstration of what can be done. And I think the nice thing here is that, the final output strategy that was taken, particularly for sample transport, was, taking the sample transport optimization output and actually competing it with third-party logistics providers. So this was the one thing that we did in Nigeria that is somewhat unique, is that we pitched an RFP into the private sector to see who could actually provide these services outside of, reliant on MOH as well as other implementing partners that we had historically funded. And we targeted 3PLs that are logistics providers that had the capacity and the fleets that could actually accommodate this. And it's in the short term, we've seen gains, obviously, in how things are working. And it's going to be interesting to see at the end of the year, what sort of cost savings are potentially driven by this new 3PL approach that Nigeria is taking on. I do know in the next month, they will be doing a complete assessment of the integrated sample transport network and looking for potential opportunities to improve it. identifying where things are working and where things are not working as well as they probably should, and looking, as I mentioned earlier, to kind of iteratively improve upon what we did back in August of last year. So in doing this, it can be very complicated, and it can be very labor intensive. There's a lot of data involved. You know, it's not just looking at the laboratory, it's actually looking at clinical site data and where the demand is coming from to do a pretty good job of understanding, you know, how to improve on sample transport lanes and to improve instrument placement. And this can take a long time. I mean, if we look at Nigeria, for example, there was over 5,500 clinics. You know, some of the smaller countries, obviously it's a little easier, but when you're looking at a country of that magnitude, it can become very labor intensive. And I also think, as I mentioned earlier too, it's, you know, when folks start seeing some of the initial maps, it does introduce other questions that people want to consider and look at as part of their optimization efforts. And it becomes a very exciting thing for the country. But many of the questions they ask, you know, there are additional data requirements that are necessary to address some of those questions. And this is one of the reasons why it can't take a significant amount of time. There are differences as part of optimization between political boundaries and the balance between access and the data that's available. I do know that there are a lot of concerns, particularly when we look at POC. I know TB has a priority to address access. And we have other programs that are looking to create efficiency. So there's a balance that needs to be negotiated as part of some of the outputs of the modeling that can be challenging for the stakeholders more broadly to come to agreement on. But I think the nice thing is that, you know, we can demonstrate an all-in, a partial, moving instruments around, and I think collectively, I think people can appreciate better, you know, the implications of a particular decision to increase access versus balancing conventional versus POC, and it's a nice way to demonstrate what can be done. It's nice to see, you know, some countries focusing on sample referral network investment, which is historically, as I mentioned, somewhat fragmented, and I think people now are getting the appreciation of integrating and looking for cost savings more broadly. But there are challenges to that, obviously, with funding streams being more parallel and a little bit of reluctance and pushback on some IPs. But I think, you know, once people actually see, you know, the potential gains, people are becoming a little more comfortable in sort of taking that overall approach. Again, as I mentioned earlier, too, the political will is very, very important. There are some key decisions that need to be made as part of optimizing the network. And some of it can be very transformative, and some of it more subtle. But I think it's very, very important to have your MOH and your National Reference Lab, you know, completely buy into this more broadly, as well as the funders, any additional donors and stakeholders at the table, to understand that everyone is investing in this network more broadly, and it's not a one individual group that's investing completely. The intent here is to inform everyone strategically so that everyone can work off of one strategy moving forward, which is very nice. But that can become challenging as part of execution. One of the things that became very evident too in Nigeria is lab infrastructure. So as I mentioned earlier, the approach was to develop some super labs. And unfortunately, some of these labs were not well equipped to support some of the larger instruments that were going to be necessary to improve sample transport lanes. So there was some infrastructure adjustments that needed to be made to some of these facilities to allow for some of these larger machines to come through. And as well as that, you know, HR capacity is also an issue that needs to be looked at very, very closely as you start implementing the outputs of the optimization. So I'm going to close with some sort of general kind of recommendations that I think folks are interested in more broadly. And I think, you know, as I mentioned earlier, the network approach is kind of the end game for us, looking at, you know, leveraging everyone's investment across various disease areas and having a more forward-looking perspective on where countries are going in relation to their lab diagnostic needs. And this is a really good opportunity to do this as part of an overall network approach and optimization strategy, and pushing for a more all-in kind of cost approach to ensure that you do have adequate funding and there are some efficiencies that can be gained to actually reach that end goal of where the lab network is ultimately going to go as part of addressing the overall needs of the country that we're looking at. You know, historically, we've purchased machines, and folks that are working with PEPFAR will obviously know that, you know, we can no longer buy machines unless there is some justification. And the push now, obviously, is for reagent rental over some of the larger machines. And what that does is it actually forces folks to be a little more cognizant of the testing volumes that are going through their facilities, because reagent rentals are volume driven, and capacity and utilization is a key determinant of whether or not a manufacturer is willing to place a reagent rental machine in a particular lab. So this is something that's very critical to look at, and lab optimization actually is one way to kind of look at this in a very evidence-based manner, and actually adds an additional layer of confidence when having discussions with manufacturers and vendors as part of, you know, negotiating a reagent rental deal for a country. I think that the nice thing too is that GIS data is scattered across many different data sources in many of our programs, and this is an opportunity to leverage and kind of bring things together so that you can actually see what's going on from a clinic perspective, a lab perspective, particularly for viral load EAD, and then actually looking at POC and looking at, you know, TB networks more holistically. So folks need to kind of look at these things, look at these very data sources, kind of pull them together, give folks a more comprehensive, holistic look at what's going on within their health network overall. I do know, as part of POC integration, there's a big push, particularly on EAD, and now we're looking at, you know, pushing for viral loads on you know, breastfeeding women as well as infants. You know, there's a really good way here to kind of model an integration that countries can afford, recognizing that currently pricing for POC is somewhat expensive. We're hoping the price does go down, and obviously that would be something that we're pushing for on our end as the access issue becomes more of a challenge to address overall. But I think as we look holistically and looking at EID with GenExpert and other machines that are already pre-existing, there's a really good opportunity here to leverage, you know, pre-existing footprints on POC and understand the impact on what that would do on your conventional network, because it will decrease testing volumes that go through that network, and you have to be able to appreciate what that change will be as part of supply planning and even pricing negotiations with manufacturers. And again, you know, ultimately we're looking for an integrated system, maximizing the use of investment across IPs as well as by program areas. And I think, you know, lab network optimization is one way of doing it. And I think it provides folks a good visibility in where their programs sit, and give folks a better understanding of where their program sits on top of other programs. And it's pretty exciting when people actually see their network on top of another, and you know, they start thinking about potential opportunities for leveraging resources and creating efficiencies more broadly. So with that, I'm going to stop. There were some complex issues and things that I talked about there, so I'm happy to answer any questions. As you can see here on the bottom, we do use LabCoP and Supply Chain Guru as some of the software applications more broadly that we do for lab network optimization, but there are other software options out there. We can provide you some guidance on what other options are out there if you do not want to use LabCoP or LlamaSoft or, you know, Supply Chain Guru and other applications that we're currently using. I know CDC has some other tools, and we're pretty aligned on the overall methodology. So I think, you know, from my perspective, folks, you know, I'm happy to take questions if countries are interested in it. But just know that, you know, whatever we're doing is not done in isolation. It's done collectively. So we would be engaging, you know, Global Fund, MOH, national TV programs, you know, CDC and other ongoing partners and stakeholders that are involved in the overall network. So it's a comprehensive approach in developing a strategy, and we're pretty flexible in the tools and the methodology, but it depends on the assumptions and the overall optimization the country's looking to do, which I mentioned earlier somewhat evolves once you actually start getting into the optimization models. So with that, I'm going to stop and just give thanks for everyone for hanging in there. That was 25, 30 minutes, 35, 40 minutes. Sorry, I spoke a little longer than I thought I should. But hopefully we've got enough time to answer some questions. So
Okay. Okay. Thank you, Jason, for that very elaborate and educative session. I know there are quite a number of questions, but we have barely 10 minutes to do this. So I will ask somebody, we will have announcements at the very end. I will ask Nicholas to ask questions from the chat as quickly as possible. We have about just like 10, 11 minutes for questions.
Okay, thank you very much. The first question is from Dr. Chais and is asking, what is your comment on having many types of machines like it is in Zimbabwe, and where, like it is in Zimbabwe, where they have over 8 different machine types?
Yeah, so historically, we think about, the Maputo Declaration and things like that. I mean, obviously, the more diversity you have, the more complex your procurement strategy has to be in relation to commodities and reagents. I do think, having that number of instruments does create some challenges. The idea would be to potentially simplify, if possible. I mean, ultimately, 2 to 3 different brands. I mean, you do not want to rely on one manufacturer if something does happen, whether it be a reagent quality related issue. It's nice to have a backup and some redundancy. I don't think there is a right answer in the number of different brands you should have, but the more you reduce diversity, obviously the greater efficiencies you can gain.
Okay, the other question is from Nicole and is asking, do you have turnaround times for the Zimbabwe EID experience before and after optimization? Do you have turnaround times for the Zimbabwe infant diagnosis experience before and after optimization?
So we do not have the before and after. We started with the before, but obviously Zimbabwe is in the process of implementing. I would assume when they went from 3 labs potentially to close to, I want to say close to 50-something facilities that could provide the service, the TAT would go down significantly. But we have not seen those reductions yet from Zimbabwe. It's too early.
Okay, the other question is from the Kenya Hub, and they're asking, what's the software tool used? Is it USAID LabCoP? Any limitations, especially in terms of numbers of records?
Yeah.
Had a challenge with 2,000 records in LabCoP.
Yes. So LabCoP is it was an introductory tool, and it was designed to be relatively simple to use to end users. And there are limitations to what LabCoP can do. So we're actually working now with Find to develop a version 2.0, which will be web-based, and we'll actually have a variety of optimization models that are a lot more sophisticated than the current version. What we do in these optimization networks in country is we do leave the country with LabCoP pre-populated with the scenarios. But due to the high volume of data flow, we do rely on Supply Chain Guru to crunch the numbers because we are doing this basically in real time. We do not have time for the software to get bogged down with high volumes of data, because many times we're looking at an algorithm within the software that could be running hundreds and hundreds of thousands of different calculations to create the best fit. So LabCoP does have limitations. It's good for visualizations. There is limitations on the speed with which it performs based on the volume of data that goes in it. So currently we do rely on Supply Chain Guru, which is a LlamaSoft software tool that has very, very robust and vigorous algorithms that can accommodate very large data sets.
Okay, the other question is from Rafael Langati, and he is asking, are all the loads infant diagnosis samples shipped to point of care labs and also referral labs? Are all the load EID samples shipped to point of care labs and also referral labs?
So yes, it becomes a mix, right? Because there are limitations to the capacity for POC. I mean, you can do 5, 6 a day at a POC site, but when you're talking about areas that have significant volumes, then yes, it's a mix. So the software can set up limitations on sample testing volumes by individual lab and actually redirect samples to conventional. And likewise, you can reverse that. You can send samples to conventional. When capacity is reached, you can actually redirect to other conventional labs or potentially POC sites. So it's up to the end users to define that criteria.
Okay, thank you. The other question is from Brianan, and she is asking, did you encounter any challenges with reallocating and moving equipment in Zimbabwe? What were the strategies you used to gain stakeholder stroke Minister of Faith buy-in for moving equipment?
Sure. So this is the reason why it's critical to have the MOH and the National Reference Lab involved in this process. The instruments that were proposed to be moved in Zimbabwe were actually from the National Reference Lab. So they had many machines that were actually residing there because eventually, ultimately that's where the program started. So they had legacy equipment that was actually underutilized within that facility. So the MOH, the lab directorate within the program, was comfortable in moving those machines. And actually, we proposed removing 2 conventional machines, 2 Abbott machines out of the National Reference Lab to 2 new provinces. And the National Reference Lab was fine with that because they actually were not using the capacity that they had at that facility. So there was no real loss to the National Reference Laboratory in Zimbabwe. But you're right, many labs do not want to lose machines. The thing here is that they had excess capacity, and there was no capacity loss within the National Reference Lab by relocating those machines. Now, the new sites that were actually selected would require a slight infrastructure adjustment to accommodate the new placement of those machines. So the ministry was very, very supportive, and the NRL had no real problem with moving those machines.
Okay, the other question is from Rafael Langati, and he is asking, how do we measure quality of results from all point of care and referral labs?
So how do we, say the question again, apologies?
How do we monitor quality of results from all point of care and referral laboratories?
Yeah, that's a really good question. And it's one of the things that we're actually looking to improve as part of our new contract mechanism. So if we look at POC, for example, and some of the procurement that we're doing within PEPFAR, we've established failure rates for POC. Anything above and beyond that would actually warrant an intervention by the manufacturer or end users to address deficiencies in overall performance. I think when we're actually looking at conventional machines, the data connectivity solutions that we're targeting with the manufacturers at this point now does provide visibility into QA, QC performance, run failures, and those sorts of things. So we are getting at instrument performance, but there are issues, I think, more broadly with end users and doing things correctly that needs to be addressed in some of these facilities. But I think the data feed is critical in understanding that, and getting a real-time feed is very, very important. So your data management strategy needs to be well structured to address those.
Okay, the other question is from Nasumba Ellen from Uganda, and she's asking,
the last one.
How does Zimbabwe's experience in EID data management, considering the main testing centers? How is Zimbabwe's experience in EID data management, considering the main testing centers? Are there challenges? If yes, what mechanisms have been put in place?
So they did, right? They had many challenges, and part of it was that they only had 3 facilities that were providing the services for EID in Zimbabwe. The expansion into expert and layer Qs obviously improved the reach, addressing the broader access issues. And we actually started looking at proximity. I don't have data on the turnaround times and the data sharing to end users as well as clinics in relation to the results at this point. But the assumption would be that the closer the machines are to the patients, that obviously this would improve.
Okay, I think there are still questions, and we may not be able to exhaust all the questions right on this call, but good enough we have an offline communication platform, the WhatsApp, which is open 24/7. Let the discussion continue on WhatsApp.
Exactly.
And Justin, I hope you are on WhatsApp. If you are not, send me your phone immediately, and then I put you on.
Okay, I'll do that as soon as I can.
because you'll have to continue answering questions.
I'm pretty sure, yes.
Yes, people are going to continue asking.
I also want to close. I mean, my email address was listed at the bottom. I don't want to feed hundreds of questions, but I mean, if a country is motivated to look at this a little more closely, please do feel free to reach out.
Okay, fine. So we will have to post this live session on YouTube. We will have to push the presentation on the webpage. So just reach out to these platforms to get to look at the information more in details. So thank you very much for that very, very exciting and very educative session. So I just have a few announcements. You remember, country teams have been reaching out to you to arrange country-specific calls. We've been conducting country-specific calls to get feedback from you, especially on the action planning and the COP19 integration. We want to share a few nuggets from other countries on how they have done this, and also pick on your experience and what opportunities still exist, and whether we have optimized the opportunity to ensure that our action plans have fully been integrated with COP19. And if there is any need for advocacy, we optimize the moments. And we also need to pick a feedback from you on how you view our programming within LabCoP and how best we could trigger our programming to suit your best test. So that feedback is very important. A few countries have already arranged these calls and others have not. Zimbabwe, South Africa, Malawi, Uganda have already arranged the calls, and we have had discussions with these countries and we have the feedback. We are still waiting on other countries. Ethiopia is set up for next week. So any other country that has not yet, of course, if you have not been mentioned among those I've read, you are not yet. Please arrange, get back to me. I sent out a mail calling out to see that we arrange country-specific calls to discuss in the country context of how things appear and how our programming is reaching or is impacting your work, or whether there's anything more we need to do to reach your expectation. So this is very, very important for us as we go into our next phase. So please arrange these calls, preferably not beyond next week, because we had planned to have this finished by the end of this month, but some countries will still lagging behind. So I request all of us to respond to this. Then the other bit, there is an opportunity for capacity building, which we sent out on the network, where we got an offer for a training within Israel, where we have been given scholarships for our members to train in Israel in a course that has been designed largely for our community in laboratory management at the Galilee International Management Institute. So please check out that invitation that we sent out on WhatsApp. We will, I think, also send it out on mail. so that all of us can take advantage of this opportunity. All you need is to find air tickets and your upkeep, your accommodation and upkeep while in Israel for 2 weeks. But the training fees were waived, and you'll have a paper, a diploma that will be offered after this training. So please, this is very important. All lab managers, program managers, and all of us related in steering programs, especially around labs, you are welcome to join that training. It will be on the 6th to the 16th of September. We still have a bit of time. Work through your framework to see that you get the other bit of support to ensure that you don't miss out on this opportunity. We are having waste management trainings. I know in the next few days you'll have an advert coming out on when our next waste management training will be hosted for the next month. You know, we do it within the first 10 days of the month. So be on the lookout for the invitation that we will set, and please make sure that you are there to benefit from these trainings being rolled out by the International Laboratory Branch. Otherwise, I want to thank all of us that have made it for this session. I want to thank Jason for, you know, making it possible to have this very educative session that we have had. And I encourage you that the questions that have not been answered, let us push them on WhatsApp. And the person who has been running the chat, if there are any questions we are not able to read, just take them directly to the chat, and Jason will going to, if he's not on WhatsApp, but I think he's already there. So he's going to be, you're already there. So he's going to continue answering these questions. Let the discussions continue. Let the learning continue, and we'll be pushing these materials on our communication platforms. Otherwise, thank you very much for now, and I wish you the best of the rest of the month. See you again, especially when we do the waste management training. Thank you very much.
Thank you for having me.
Nice day, nice morning.
Bye.
Nice
Thank you all.
Afternoon. Bye.
Bye, everyone.
Bye to everyone. Yeah.